know that nearly 80% of US adults already meet the criteria for stage A or B heart failure? And the traditional focus on late stage treatment has not stopped the heart failure prevalence or mortality from rising. So, we have a new statement from the Heart Failure Society of America, HFSA, as well as the American Society for Preventive Cardiology, ASPC, about preventing heart failure. And we are so happy to have two guests on to today to discuss their paper, the insights, and everything you need to know as a clinician. It's a multidisciplinary approach. So if you are involved at all, you will be able to use these practices. Today, we have Dr. Anu Lala, who is an associate professor of cardiology at the Mount Sinai Heart Hospital, as well as the co-editor-in-chief of the Journal of Cardiac Failure. We also have Dr. Martha Gulati, who is a professor of cardiology at Cedars-Sinai, and also the past ASPC president. Thank you guys so much for joining us today.
Oh, thanks for having us.
We're so excited to be here.
That's so great. And I'm so excited to hear everything about your latest paper, this latest statement that I think is really going to help a lot of people here. So I'll just let you guys just go ahead and discuss.
You know, Martha, I have to thank you first and foremost for this opportunity because it's kind of a dream come true. You've always been such a light in this space, and you've emphasized prevention across patients' lifespans for years, right? And us as heart failure cardiologists, I don't think really appreciated the importance of emphasizing prevention across patients' lifespans in a formalized way until recently. And so I think this joint statement between the HFSA and ASPC really represents a paradigm shift. You know, we wrote this together, and we've talked about this so much, that prevention is in heart failure is not just a phase. It's a mindset. It's a culture shift. It applies not only before the onset of disease, but it continues after diagnoses, even after the heart has been replaced, let's say by a VAD or a transplant. What are your thoughts? Like, what are your initial takes on this?
Well, thank you, Anu, and thank you for joining me on this journey, because I think we both have said how much this was needed, and really thinking about how can we really get our communities to both together, but also to focus more on the prevention of heart failure. I think, you know, we can't just call heart failure all the time, meaning consults for heart failure. It's just too much, and the volume of heart failure is increasing. And there is so much we can do if we start preventing heart failure. And so I think it is a time that the preventive cardiology community can join with heart failure, which seemed like two extremes. And yet now we've created a strategy for all of us to identify and manage cardiovascular risk earlier, and putting into cardiovascular risk more than atherosclerosis, but specifically adding in this important disease, heart failure.
I couldn't agree more, obviously. You know, we keep getting asked, why does this statement matter, right? What's the big deal? And I think, you know, heart failure, we know, affects over 6 million American adults a day today. And every paper about heart failure starts out with that statistic. And this is projected to be almost double by 2050, right? Crossing 11 million. And despite all the therapeutic advances that we've encountered and that we're so humbled by and excited by, 1 in 4 is readmitted with heart failure after an index hospitalization within 30 days. 1 in 5 dies within 1 year. The lifetime risk of heart failure is 1 in 4. The costs, over $30 billion annually. So these statistics are sort of just staggering. And I think it's begging us to recognize the fact that we need to move earlier in the course of disease. We need to think about heart failure as a preventable condition and disease state, rather than this inevitable outcome that is the end result of all of these accumulated risk factors.
Yeah, and I mean, I think the idea, if we keep having this conversation, that heart failure is preventable, and that we can recognize who is going to go on and develop heart failure at young ages. Those are the people we need to be targeting. Prevention can actually start decades before anyone has any symptoms or a label of heart failure. And to be honest, a label of heart failure is a really bad thing. I mean, people's outcomes are so terrible. And although, like you said, we have these new medications that can help, but if we do more prevention up front, that's where we can really make a change so that patients don't meet this word heart failure. And you know, the word heart failure carries with it such a negative connotation. But if we start really identifying the people at risk, they may never meet those words. And that's what we want to do. We want to change the trajectory, and we want to change someone's lifespan. If we can identify them early before they don't feel well, that's the time to really start our preventive strategies.
Obviously, I completely agree. And I thank you and our Canadian colleagues for being, I think, in my opinion, more forward thinking with respect to the nomenclature and emphasizing function, because it allows for us to then think about care of an individual across their lifespan, not just once they've had this diagnosis. Not to mention, obviously, the implications of the word heart failure and what it means for patients. But you know, one of the things that I think we've all, as a huge multidisciplinary co-author group, have kind of emphasized in this statement is that prevention has been framed across the lifespan. And we've said that multiple times already, not only for primary prevention for those patients who are at risk for heart failure, but also secondary prevention amongst those patients who already have the diagnosis. And then how it can be applicable in a tertiary prevention kind of framework for patients who have gone on to get an LVAD or a transplant. What are we doing for them? What do we do when we see those patients in clinic? We're managing their hypertension. We're addressing obesity if present. We're managing their diabetes, their chronic kidney disease, right? So again, this framework of recognizing that prevention is applicable no matter what stage, so to speak, of heart failure you are at, whether you're at risk, whether you have pre-heart failure, whether you have established heart failure, or whether you've already experienced heart replacement therapy, I think is one of the things that we enjoyed kind of formalizing and articulating.
Yeah, and along those whole stages of prevention, wherever we meet the patient, we know that the same risk factors still matter. It doesn't matter if we're talking about primary prevention, doesn't matter if we're talking about secondary or tertiary. We need to be treating those cardiovascular risk factors that will have the potential to worsen heart failure. And those include, of course, the traditional risk factors that we all know and love, or at least appreciate, things like hypertension and diabetes and obesity, but also to consider things that are specific maybe to the individual, like sex-specific differences, genetic predispositions, environmental exposures, the life's essential aids that affect our overall cardiovascular health. We need to be asking about them and addressing them and trying to modify the ones that we can. And I think this is the way that we start seeing the whole patient in both the biological context as well as the social context.
Yeah, I mean, you're basically expressing the fact that most of our patients don't have isolated risk, right? They're interconnected systems that are under strain for an individual. And I really like this critical shift that we are all as a healthcare community recognizing of emphasizing cardio, kidney, metabolic health, right? Not just disease, but health across the spectrum. I think that framework is really helpful. And I think it challenges us to adopt a more proactive, integrated, and longitudinal approach, right? We all know risk scores are very helpful, but they don't always capture individual risk, right? They're not always applicable to everyone. They're great for initial framework. It's good for awareness building. But I don't like to say but, or, but, and, this cardio kidney metabolic health framework, I think, really emphasizes the interconnectedness of organ systems and the fact that we can't be treating patients in silos, not only from a caregiver, like a healthcare provider perspective, but also, steatotic liver disease is my problem. Obstructive sleep apnea is my problem. PCOS is my problem. Why? Because these all represent derangements across the cardio-kidney metabolic health of a patient, and they all portend increased risk for the development of heart failure. And I really like what you said before. It's not just about ASCVD risk. It's not just atherosclerotic burden. It's prevention of heart failure, which is so broadly applicable.
Yeah, and as you pointed out, is increasing and becoming the leading cause of hospitalization and the highest cost for our health systems is heart failure. So we do have a lot of work to do. But I love how you said, looking through that lens, that kidney metabolic lens, I think that if we start viewing prevention through that, it really starts prioritizing our therapies. What should we be using? We have now a lot of therapies in that space. And I think, thinking about both the medications we may use, like SGLT2 inhibitors, GLP-1 receptor agonists, nonsteroidal MRA, finerenone, starting those earlier have the prevention to really forestall disease progression or even having the disease at all. And I think that, like you said, it's everybody's issue too. We're working, these are areas that we'd be like before, we're not going to tread on the kidneys and we're not going to tread on the liver. There's specialists for that. And even when we might not want to treat diabetes, there's somebody to do that. And now I think that we're seeing this intersection of what we all do with our endocrinology colleagues, with our nephrology colleagues, with our hepatology colleagues. And it really is the best way, I think, to be treating these patients and seeing it from this common lens.
Yeah, I mean, this. I am currently pursuing an integrative medicine fellowship. And while that can be met with some trepidation, depending on how you interpret that, for me, it represents the need to go back to where we used to be as a healthcare movement, which was being holistic, right? And not being so super subspecialized that we say that we only are responsible for one domain or one entity, but rather, I think prevention and this framework that you just mentioned really is the way that we can allow for holistic, multidisciplinary care to be delivered to our patients. And that's what they deserve. That's what we want, right? I think as we're aging, we recognize that we also are facing, different health challenges. And what we all seek is to be seen as a whole person. And that means being treated as one. And that also for us, and I don't mean to get too woo-woo, but it means for us that we need to recognize that all of these body systems play into one another. The health of one organ system impacts the other, particularly as it applies to heart failure. And I think, you mentioned Life's Essential 8. How many of us, I mean, you probably do as a preventive cardiologist, but, in heart failure clinic, I'm not necessarily addressing sleep. And of course, we mentioned diet and nutrition, but we're often centered just around sodium guidance. And we need so much more evidence in that space. We're talking about exercise, but then it becomes a real challenge, right? And so that's where I think rehab comes into place. We need expanded indications for rehab. We need better coverage for rehab, access to rehab. But if we use this Life's Essential 8 framework, including, for that matter, psychological well-being, to guide our visits with patients, I think we'll never forget the important aspects of prevention across the spectrum of disease.
Yeah, just like we can't ignore the important parts of, advanced heart failure, we cannot forget the importance of things like our patients' sleep, their diet, their physical activity, their psychological health. All those things need to be core components of patients that we're caring for. And that's true along the entire spectrum. But I think the more that we start working together, the more that these systems, this team-based approach becomes what we do. It's not that everybody has the time to do everything, but we can work together so that we make sure that the patient in its entirety is taken care of. And I think that's I think an important point we make in our scientific statement is how this is a team-based approach and how this is also a whole person approach to reducing the risk of heart failure and treating those with heart failure. The idea that must be along the entire lifespan and along the spectrum if you happen to advance to different stages of heart failure.
I think one of the things that I have, just by working on this, working with this incredible co-author group, multidisciplinary individuals across nursing, pharmacy, prevention, heart failure, genetics, I think I have increasingly become more proactive rather than reactive. Even amongst the patient population that I see, I'm ensuring biomarkers are assessed, not just if you have a pre-existing diagnosis of heart failure, but also if I'm considering you at risk. Assessments of albuminuria, I think we're recognizing the incredible importance of doing that across the spectrum of heart failure, whether you're at risk or you actually have heart failure as well. I think more to come in terms of polygenic risk scores with respect to genetics. AI predictive models. I know we have models and risk tools, but like we said before, there are some shortcomings there. So I think we're really excited to see where they'll be headed. And I think it really is calling for this paradigm shift, as we've already mentioned, but also this underlying humility that we have such a vast population to address, and we need to do it together, not in our silos. We need to employ whatever diagnostic aids that we have as sort of assertively as we would want for our own family members, to kind of bend this heart failure curve, to bend and change the statistics that we're seeing that are so troublesome.
Yeah, I think you're right. This is a paradigm shift, and it's going to hopefully change how our community addresses things. I also loved how you tripped over the word albuminuria, because until it becomes part of our lingo, we're going to trip over that word. And yet this is something that we really need to do. I feel so strongly that that's one of the easiest screening things that we can do to identify people at early risk. And, it's beyond looking at just glomerular filtration rate that we've used as a measure for chronic kidney disease. And I think that, again, the more we start learning and teaching our colleagues how to do prevention at all stages, this is how we change the trajectory for our patients.
I couldn't agree more. I think it's a collective call to action for all of us. I'm so excited to unite preventive cardiology and heart failure care, hopefully to deliver the promise of a healthier future.
I think that, prevention is always the most important part of cardiology. But now if we make it for all of us, I think we'll realize everyone's a preventive cardiologist. And prevention is not the beginning of the story. It's throughout the lifespan. And the more that we know that and recognize that, we'll take the best care of our patients and hopefully take failure to function.
Beautifully stated. And I hope that the people viewing this will learn something from this talk as well as the paper. Where can people read your and your co-author's paper?
Well, our paper is now in 2 journals, in the Journal of Cardiac Failure, as well as the American Journal for Preventive Cardiology.
Okay, we will make sure to have that be accessible for people to view and read and talk to their multidisciplinary team. I think love the whole team approach and emphasis on that, because I know we have a lot of various people in various roles who are following this page on cardiovisual, your place for clinician-driven cardiometabolic education. And thank you both so much for this conversation. I think it was just, again, just beautifully said. You can tell you guys are very passionate about it, and I think it's really going to help so many people. So very fortunate to have you guys on today.
Thank you so much.